Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
A Frenchman in the house today, a professor of endodontics, Dr. Pierre. I'm going to allow Dr. Pierre help me how to pronounce his last name. What's your last name, Dr. Pierre?
So my last name is, in English way, it's Wohlgemuth.
Wohlgemuth. Okay. Dr. Pierre Wohlgemuth is an assistant professor currently at the Colorado School of Dental Medicine. Today, he wants to teach on are you treating the right tooth? That is a very important question. Doctor, I'm going to allow you to introduce yourself. Just to give a brief of your, how you've come into dentistry in the United States and endo, for that matter. Without much ado, I'm just going to give you the floor, Dr. Pierre.
Sure. Thank you, Dr. Uvo. I really appreciate the invitation. Hello, everyone. First of all, I'm going to share my screen in the same time. If you give me a second, telling my background and how did I came back in the US, I came in the US, will probably be a little bit long for the time that I have to present this lecture, to be honest. But yes, I have a DDS from France. And I did a little bit of back and forth with the US because I did an international program. And then I went working in Switzerland. And then I came back in the US to do the postgrad program. And then I went into teaching. So it's, as I say, it could be kind of very long for me to do that. In the meantime, let me put my screen up there. And let's start this presentation today. So as Dr. Uvo said, the title of this presentation is, Am I Treating the Right Tooth? Why? Because I think it is a very important topic. And instead of really long introduction about myself or whatever, let's jump into the presentation itself and let's jump into a case that we can discuss together. So I think everybody can here see this periapical radiograph of tooth number 30, or depending on your numeration, I think it's 4.6 or 46. And I think everyone can see that mesial-occlusal caries that exist there. And now that you have this radiograph in memory, I think my first question for you, and I have some polling question that you should be able to answer today, is what is your endodontic diagnosis here? So let me pull up our first questions. And obviously I'm using the American Association of Endodontics diagnosis. So I don't know, depending of where you are from. And I hope you can actually see the polling. I'm not sure you can. And if I can have a little bit of feedback on that. I don't know, Dr. Uvo, if you see the polling or if anybody else see the polling, because I think I launched it. Okay, so I think I have one person who answered.
Yeah, I think they can see.
Perfect. I can see more answer coming in. That's excellent. I'm going to give you a couple of more seconds here just to answer. And don't hesitate to answer. First, it's anonymous. There is no harm on it, and we're all here to learn and discuss together. So I see there is a lot of things all over the place. We have some pulp necrosis, we have some irreversible pulpitis, we have some symptomatic irreversible pulpitis and symptomatic apical periodontitis. I think, let me just end this poll here first. And the second question that is very interesting here is, what will be your treatment of choice? And hopefully you can see the different propositions here based on the diagnosis you just actually guys met. Can you tell me what would you do for this case here? So I have a couple of answers that are coming in. So I see that people are more trending toward non-surgical root canal treatment. Here it's like about 80%, so 4 or 5 of you guys, and let me end the poll here and make actually here this statement. You don't have enough information with just the radiograph I gave you to make a diagnosis and to decide how to treat these tooth. And that's the whole point here of that presentation today. So if you have ever asked all of yourself this couple of questions, is this tooth the problem? Does it need a root canal therapy? Is this case too advanced for me? Hopefully at the end of this presentation today, we will be able to answer these questions. When I look at a preoperative radiograph or radiograph in general, for endodontics, I think there is two main parts to get these pictures right. Endodontic diagnosis, and this is the first part we will talk about today, and then case selection, that will be our second discussion for the day. And if you only have one of this information, you cannot get the entire pictures of your case. And unfortunately, only if you have both of them, you will be able to get the big pictures and achieve the nice results of the root canal treatment if it's needed. And this presentation should help you in this kind of cases to either know that you don't need to treat, like on the left side, that you actually need to treat, like in the middle, or maybe that you need to extract and not to treat on the right side of your screen here. Couple of words about myself, more than what you have. I come from this city, like small-ish city in northeast of France called Metz. But I think the real difference from probably me and a lot of other people is these are all the places I have practiced either dentistry or endodontics in the world, as short as 1 week, as long as 2.5 years now here in Colorado. I saw that some people were from Nepal, actually. So yes, I actually went to Nepal and been there for a week and did some work there and hopefully did some good. So that's what I like. I like going abroad. I like to help like population in as well. That's a couple of pictures of different places I went to. So if you have any questions today, you don't have to keep them for the end. If you want to keep them for the end, I'm perfectly fine for that. Now I have the chat open on one side of my screen. And if you have questions, I will answer them on the fly. So you can place them in the chat and I will try to answer them while I'm lecturing in the same time. So let's start in our very first big part today, which is the endodontic diagnosis. And this is extremely important for me because if you don't nail that, you will run into trouble such as opening wrong teeth, treating teeth that don't need to be treated, missing teeth that needs to be treated, and missing some important informations. So endodontic diagnosis, there is three very main components that are extremely important. First, the chief complaint and the dental history of your patient. Second, the clinical findings. And last, the radiographic interpretation. And only once you have these three components, you are able to get this information and deliver your endodontic diagnosis and then later on your treatment. If we look at the case we just talked about in the introduction, you can see that at that point, you only had the radiographic interpretation of that case. You just look at this radiograph and you cannot make an assessment on a diagnosis, not even on the treatment of this case, purely based on this radiographic interpretation. So let's start our investigation. Let's first talk about chief complaint and dental history. It is basically your subjective findings. It's all the information you're going to be able to extract from your patient by just listening to them and talking with them. That's why I really think that listening in this situation as a dentist, you should spend the time to listen to your patient, will give you already a very big amount of information that you can use to draw a diagnosis. And it's not the only point in endodontics. I think it's in general in dentistry. And the first things you get is the patient chief complaint. And you have a couple of examples here of patient chief complaint that you can get. But more than describing some of this chief complaint, I think what is very important is, again, depending where you're practicing and what type of setting you have for your practice, it could be very interesting to train your front desk, because the first person usually that get hold of the patient is your front desk. And they should be able to recognize and probably notes and give it to you later. What was the kind of chief complaint of the patient over the phone? Is it something urgent? Is it something not urgent? Usually the patient will by themselves give them already a couple of very useful information that you can start to get to be able later on to draw your diagnosis. Now, after that, you start to look a little bit into medical history. I'm not going to go over medical history in general. There is no time for that here and no point. There is 3 specific medical history I would like to really point out and kind of red flag here. Patient who already have neuralgia, so that type of patient can easily have pain that mimic endodontic pain but are not. Patient who have a history of cancer can have lesion, especially radiographic lesion, that could be metastatic from other cancer area. And this is something you want to keep in mind and kind of raise a red flag in your mind. And then people who are taking biphosphonate therapy for osteoporosis in general, but for other pathology as well. This patient sometimes can have some intraoral lesion that could mimic some endodontic infection or lesion. And this is something you want to be aware as well. And then I'm sure the next things you know is the dental history. I think what is important here is when was the last dental visit of the patient and any work that was done recently. Obviously, if it's one of your own patient, you already know what work has been done because it's in your notes. Now, if it's an emergency patient, it could be interesting for you to ask these questions and know what was the last work done. It could already kind of drive you toward one or more other direction for your future diagnosis. Now, the important slide in this subjective information part is this one, the patient interrogatory. And that summarizes all the questions you should ask your patient to get the information that you will need to draw your diagnosis. So a very easy way to remember which question you need to ask are this OPQRST memorized technique. So, O goes for onset. So you want to know when did the pain started. P goes for provocative or palliative, and we want to know what is creating the pain, what is alleviating the pain, relieving the pain. Q is for quality. It's like what type of pain it is, because depending on the pain, it can drive you to one more other direction for your diagnosis. R is for region. Where is it located? Can the patient locate actually the tooth that is the problem, or is it more the area? It could make you a difference between an odontogenic and a non-odontogenic pain. S is for associated symptom. Is there any other symptoms around? And T is for time course. How long does usually last the pain? When did it start? And here I just drive a very easy conversation between dentist and patient where you get basically all of this answer and questions, question and answer more into that direction. So for example, when did the pain start? It started last night. What does cause the pain? Every time I drink something cold, how would you describe the pain? It is a sharp shooting pain. Can you tell me where the pain is coming from? It's exactly coming from that specific tooth. Is there any other symptom associated with this pain? I only have pain around that specific tooth. How long does the pain last? It lasts for several minutes. And then you're done. It's basically a 2-minute conversation with your patient. And with already all this information from here, you start to have a pretty interesting idea about what could be actually your diagnosis. Yes, you still need the 2 other parts we're going to talk in a minute about. However, here you have already gathered a lot of very interesting and useful information. The very important point as well here, and again, this is should be a red flag in your mind. Every time a patient describes the quality of the pain as burning sensation or electric shock, this should raise a red flag in your mind. Why? Because in this specific case, it's usually a non-odontogenic pain that creates this type of sensation. So when I have a patient who tell me that he has this type of pain, I will pay even more attention to my clinical testing later to make sure that it is really a pain that is coming from the teeth, or is it something that's coming from somewhere else? And that's it. You're done with your first part of the information you need to gather for your diagnosis. Now we can jump into the next part, which is the kind of bulk of here. It's the clinical findings. And this is your objective findings. This is everything you're going to get by examining your patient from extraoral to the tooth area, or at least the area itself that you are and the patient are interested in. Let me just see something about coding. Yep. So again, we coming from extraoral examination to intraoral examination to endodontic testing. And you really want to do this in this specific order. You don't want to focus right away on the area that the patient is pointing out. You want to have a global view first, and then goes little by little toward the area of interest. I saw something. Sorry, I saw something actually. Another question in Q&A. I'm going to answer it right now. The question was, which need more investigation, electric or burning? It doesn't really matter. It just say that non-odontogenic pain have this usually describing sensation by either electric sensation, electric shock-ish, and burning sensation from the patient when they're verbalizing it. And this is just an information for you to keep in your mind for the rest of your future investigation. That should just raise a red flag in your mind. Okay, so extraoral examination. Obviously, you want to look at facial asymmetry of your patient. And you can see here, this is one of my co-residents at the time I was at NYU University. He took these pictures on one of his patients. This is not my co-resident. You can see the difference between the left and the right side, and you should note that. You should note loss of definition. And remember, usually extraoral swelling, like in this case, are from odontogenic origin. The next things you want to analyze after that is the intraoral examination. So you want to look at swelling, stoma, paralysis, like in this case, you have a little swelling on the apical area of tooth number 10 or 2-1, depending of where you are from. Some ulceration, or 2-2, depending where you are from, sorry. Now, when you're doing an intraoral examination and you see an open stoma, paralysis, however you want to call it, why you should always trace this open stoma? Because of this specific example. So I'm sure here everyone can see that there is an open stoma, paralysis, or whatever on the apical of tooth number 8. If you don't decide to follow this open stoma with a gutta percha point, you might think that number 8 is the problem. And again, your diagnosis will compile all the information you will get, but you might think that. Now, what I can show you is when you take the intraoral periapical radiograph of this case, you see that actually this stoma is leading toward tooth number 7 or 1-2, depending on where you're from. So you don't want to be mistaken. Every time you see an open stoma, use a gutta percha cone of minimum 30 and trace that open stoma. It will definitely help you to know exactly where you need to go. I do see another question here. When there is a swelling, do endo directly or antibiotic first? Well, first, you want to know if the swelling is really from odontogenic origin, so going through all the steps we're talking about today. And then let me answer your question at the end, if you don't mind, because it's a little bit lengthy answer that I could give you. Let's continue. Once you are done with extraoral and intraoral examination, you want to move toward starting your clinical testing. First one, I'm sure you're all doing it. You want to start by palpation. So you palpate nicely around the area, just noticing when there is pain. And then you move toward percussion test. Percussion test, you want to nicely tap on the teeth, and I'm sure you all know that as well. You don't want to be too nice. There is no reason, and then the patient will tell you when they start to have some pain. The reminder here for you guys is that percussion sensitivity only indicates periradicular inflammation, which means inflammation of the periradicular tissue. You're only triggering periodontal nerve fiber, basically. It doesn't really tell you anything about the status of the pulp. You can have sensation to percussion as soon as there is bacterial contamination or byproduct contamination in the pulp, and the pulp is still vital, as when the pulp is necrotic. So a positive percussion test doesn't mean that the tooth is, for example, necrotic. You cannot draw a diagnosis directly from that. You still need to continue more and more testing to be able to draw a diagnosis. Mobility, and I think I can kind of quickly go over this slide. You just note the mobility of the tooth. And then comes probing. And probing for me as an endodontist is actually very important. I'm married with a periodontist, probably why I like probing so much. But I do think it gives you a very valuable information. And why? Because it helps you detect big evidence of vertical root fracture. And you can see here in this example, how there is a narrow periodontal probing. When I say narrow periodontal probing, I'm talking about this type of periodontal probing. So when you probe the tooth, you go from a 2, 2 to right away to an 8, and then a 2, 2 again. This is an isolated deep pocket that usually in 70% of the case, according to Ing, is characteristic of a vertical root fracture. Now, the other type of probing that is more of a periodontal issue is usually the second one you can see on the lower right side. It's a 2, 4, 6, 4, 2. You can see this broad increasing and decreasing of the periodontal pocket compared to the very deep, isolated probing there. And then you can do a bite test, depending here on the chief complaint of your patient. Usually, if they complain that when they bite on something, it's painful, you will test every cusp of a tooth, of teeth even. And then what you need to remember is pain upon releasing. So the patient bites on the test, and then you ask him to kind of quickly release. If the pain comes when they release, it could indicate a fracture. And I'm just putting here in very important color, cool, because it doesn't mean it is obviously a root fracture. You will have to do a little bit more test and visualization to make sure that it could be actually a vertical root fracture. This type of sensation will be described by the patient with vital teeth due to the movement of fluid to the pulp by the fact that the crack kind of closes when the patient is biting and reopens suddenly when they're opening. In previously treated teeth, unfortunately, you don't get the same type of sensation. Next, let's talk about Trance illumination test. I don't know if you guys have a Trance illuminator in your offices, but this here is usually what you will see if there is a crack or a fracture on a tooth and you're using a Trance illuminator. Remember to shut down your overhead light when you do that. Place it on the side of the tooth and see if the light is coming from one side to the other of the tooth. If it doesn't, then you will see that crack line existing there. If it does, there's probably no root fracture or crown root fracture there. Now let's talk about what people used to call vitality testing. And it is not vitality testing anymore. It's because you're not really testing the vitality of the tooth, and we will talk a little bit about it in a minute, but you're really talking more about sensitivity testing. And it will require interpretation on your side. These tests are not just, oh, this is the answer, this is my diagnosis. This test will really require interpretation from you. What I mean by interpretation is if your patient is telling you that number, for example, number 3 here or number 16 is the problem, the teeth you should actually test are not just tooth number 3, but you should test the first upper molar, you should test the second upper premolar, the second upper molar, as well as a contralateral tooth to have a baseline of what is a normal response to your testing. And this is the bare minimum number of teeth you should actually test to be able to get a good idea about the results on any one of these teeth and which one is actually the problem here. Because if you get kind of narrow vision, and as you can see here, let's imagine that the patient that you have his chief complaint is, I have pain when I chew on my tooth. And he is pointing to tooth number 30 or 46. And you take a radiograph and you see that this tooth has a previous treatment and a restoration that is definitely not the best here. You test this tooth and you get a sensitive response to percussion. You might think that because you only tested this tooth, that this is the tooth that is the problem and it needs to be maybe retreated or extracted. However, if you had tested all the teeth that we just talked about, so the neighboring teeth and the contralateral, you will have realized that tooth number 31 was not giving you any response to cold testing and EPT, and we'll talk about this in a minute. And then that this tooth was actually the problem. So it means that first, patients have hard time to actually localize exactly where the pain is coming from. And this is an information you should keep. The second one is you really need to test the tooth that patient thinks is the problem, the neighboring ones, and a contralateral one to have a better idea for your diagnosis. And this is just a final radiograph. So let's talk about the first sensitivity test, the kind of gold standard one that everybody should be doing, the cold test. Here, I do think I have a polling question, if you give me a second. Yep. So for you that you're using in your office, which technique do you think is reliable technique to use as a cold test technique? And hopefully you see it. I think you can choose actually multiple answers in this one. I'm going to give you a couple of seconds to answer a little bit more, and then I will just comment on that. So very interestingly, I see that a lot of you are answering air water dental chair syringe seems to be an adequate cold testing method. And I'm going to end the poll here. Yes, I see people as well using endo ice. So let's be honest all together here. And let's decide from now on that this is going to be what you should be doing for your future. Is any one of this technique you see here on this slide, either it's air water syringe, either it's the cold water you put in the anesthetic cartridge in your freezer and that you're using on your patient. Either it's relying on when your patient is telling you like, oh, when I breathe cold air, it's painful. These are not reliable cold testing method. You shouldn't be using this. However, what you should be using is, for example, DDM or endo ice here. Why? Because it achieves a temperature of minus 26.2 Celsius degree. And this is decreasing the temperature enough on the tooth when you're testing it to trigger a correct response from the patient. The ideal cotton pellet is a number 2, and you want to spray that for 5 seconds. If you just come and do, it's not going to work. And you can see the video here, hopefully. This is how much I spray my own cotton pellet. And it's about 4 to 5 seconds to achieve the decreasing in temperature on the cotton pellet enough to decrease the temperature enough on my tooth down the road. And you want to hold that cotton pellet on the tooth for until the patient raises their hand, as you instructed them, or to 15 seconds. And 15 seconds is extremely long. If I stop talking for 15 seconds right now, we're going to all feel very awkward because it's going to be a very long time. And this is really what you want and what you need to do, because some patients have delayed response. It's delayed, but it's still vital. So remember, either until they raise their hand or for 15 seconds. Now, next question of our polling, and I think this one is an important one as well, is what do you think about cold testing on crown? Do you think cold testing on crown are reliable, or do you think they are not? I'm giving you a couple of more seconds to answer. I see it's not even a tie. Actually, most of you are thinking here that cold testing are not reliable on crown, because I have 80% that's saying no. And it's great that you're attending this CE seminar course today, because I'm going to change your mind. Yes, cold testing are reliable through crown. Either it's PFM, full ceramic, zirconia, it doesn't matter. You might need to leave your cotton pellet for a little bit longer. And that's why I was talking about 15 seconds earlier. And try it on your next patient. You will see. I mean, I tried with a lot of my students here, and they don't believe me until they try it on a patient. And my advice for you is, especially if it's, for example, a gold crown or even PFM crown, use the occlusal surface. It's transmit a little bit better, the cold, but leave it either until the patient raises their hand or 15 seconds. And you will be surprised to realize that this is a very good, reliable method on crown. So now the big questions. You've done your cold testing. What if your cold testing is negative on multiple teeth? Because we said earlier, we need to try multiple teeth to have a base value of our testing, as well as making sure the neighboring teeth are not a problem. You can see this case here. You can see this for lower anterior and with a periapical radiolucency on tooth number 23. And you can see here the testing. What you can see is there is no response on all of these anterior teeth. So what do? Do you treat it? Do you don't treat it? Do you just send it to someone else? And these are real cases, especially when people get older, they respond less to cold testing. So what if I was telling you that there is a test that you can do and that will help you in these challenging cases, in most of these challenging cases, actually. And this is the electric pulp test. I do think, let me just see, I think I have a polling question for that, actually. Up here, I'm launching this here because I'm very interested by that. Is, do you have an EPT in your office? Do you own one? Do you use one? Is it in a drawer in your office somewhere? Do you don't? So I see that most of you don't have, and hopefully I can maybe change your mind today again, and maybe you can buy an EPT. And to let you know, here in the US, I think you can find an EPT through Henry Schein for about $400. And I'm going to end the poll here. And I think this is probably one of the best things you can buy to help you in your diagnosis in general. So electric pulp test, I put it here. You can see two different machines here. They're about $400. What you need to remember is when you do it, you want to put a little bit of toothpaste on the probe to create a nice connection between the tooth and the probe itself. You're going to get a value. So what happens is if you're not really familiar with it, so you place it on the patient tooth. Some of this requires the patient to hold something. Some of them have a hook, like a apex locator. And then when the patient feels something, either he release and you see the number on the screen, or the patient, if he feels something, raise their hand and you see the number. What is important to remember is the number doesn't mean anything. There is a caveat to that. What you're triggering here is only nerve fiber. It doesn't give you an idea about what's the status of the tooth itself, just that there is vital nerve fiber, which means ideally the tooth is vital. But you cannot say it's inflamed, it's not inflamed, for example. What I was meaning by the number doesn't mean anything is this one. As long as the number on the screen where the patient release or raise their hand is 0 to 79, so lower than 80, the tooth is considered as vital. Now, if this number reach 80, tooth is considered as necrotic. And that gives you a very good idea. So now, same question again. Do you think the EPT is a good test for your full coverage crown? Do you think this test could be done on this full coverage crown? Either it's zirconia, either it's PFM, either it's full ceramic crown. I see that we're more of a kind of tie here. Actually, people think yes. So I hope you're not influenced by the fact that I just say yes earlier on this. So we are almost at we are at 40-50. Let me end the poll here. So here, unfortunately, no, you shouldn't do an EPT on crown teeth. And why? Because it will transmit some of the electricity to the neighboring teeth, and you could have false positive or false negative results. So you shouldn't do anytime there is a full coverage crown of the tooth, you cannot do an EPT on it. So let's go back to the case we just talked about before the EPT part. So now remember, you have this case. You have been used to cold and nothing was responding. Now you're doing an EPT, and what you realize is all of these teeth have results lower than 80. And as I said earlier, it means that these teeth are actually still vital. So this lesion is a non-odontogenic lesion based on your diagnosis. It is not coming from the tooth. So at that point, the next step is probably a biopsy, but there is no need right here, right now, for a root canal therapy on this tooth. If you had done a root canal therapy, you might end up down the road with the tooth not healing. And what do? You extract it, and then the lesion might stay there. There is here no need for root canal therapy right now. Maybe the biopsy will say something else, but right now there is no need. And the EPT had helped you to determine that. Other tests that you can do a heat test. Usually to match the chief complaint of your patient. If you don't get reliable results with the cold and the EPT, and the patient is complaining about hot heat sensation, you can do a heat test. And the other one, how to take biopsy, this is outside of the scope of that lecture. I really thank you for the question. This could be a completely another lecture, to be 100% honest with you. Let me continue the presentation. Cavity test. So cavity tests are a little bit barbaric in a certain sense. You really need to get the patient on board. However, it is extremely useful, and I'm going to show you a case right now. What you need to remember is isolate the tooth, and then just drill with water, and as soon as the patient raises their hand because they feel something, you stop and you restore it. Why is it important? You remember that case in the introduction we talked about together. You can see that all the response to cold are normal on all of these teeth. All the EPT are less than 80. So now you can ask yourself, is it both false positive for cold and EPT? Should I do a biopsy right away? Maybe I can try a cavity test. And this is what I did. I got the patient on board. We tried a cavity test. And as soon as I drill on that tooth, the patient was responding, meaning the tooth is alive in accordance with the previous test we've done. But that, in certain situations, can be extremely useful. There is real vitality testing that exists, such as pulse oximeter and laser Doppler, that gives you an idea about what exactly the status of the tooth is. It inflamed, not inflamed. However, this is only limited to research. This is not applicable to clinical situation. It's way too difficult to use, and this is not practical at all. So what I want to offer you today here as well is a chronology for your endodontic testing. First, the minimal endodontic testing you should do for any one of your cases are the 4 following one: palpation, percussion, probing, and cold. In the second time, if your cold test is negative, or if you have inconclusive results, and if you can do it, you should do an EPT. At the last resort, once you have used all of this testing and you still cannot reproduce the chief complaint or cannot draw a diagnosis, you can use some of this other testing: heat, bite, and Trance illumination. So now let's move on to our last part of the diagnosis, the radiographic interpretation. So for the sake of time of this presentation today, I'm not going to go in detail about radiographic interpretation. I can probably lecture you 2 hours on it easily. What I just want to show you is that these are all the information I usually gather from my preoperative radiograph. So a bite wing and a PA, you can see how much information I can get from a bite wing radiograph on the left side, and all the information I'm getting from a periapical radiograph on the right side. That's everything I look at before anything. Which start first, cold or heat? You should always do a cold first. As I put on that slide, the first tests that you should always do are palpation, percussion, probing, and cold test. Heat only if you try to match the chief complaint of your patient and your cold tests were not very reliable. So going back to radiograph, this is all the information I gathered from my radiograph. So there is always people ask, and the right to ask, and I'm sure some of you are asking right now, is what about CBCT? Should I take a CBCT every time? Yes, CBCT are extremely valuable in diagnosis. You can see here tooth number 2 and tooth number 17. We don't really see anything special. The post is a little bit off axis, but the patient had pain there, so I decided to take a CBCT. And what you can see is that there is a root fracture, most likely caused by the post there. And I think you can see it here on the arrow and in the area circle. So yes, it is really useful. However, do you need to take CBCT for every cases? I don't think so. Again, I could lecture for a very long time on that specific topic, but I really don't think you need to take CBCT for every cases. You can refer to this AE and AO-MR joint position statement that is available online, or the Colleague of Excellence on the AE website that is free of access to everyone about when to take CBCTs. So now we have all of our information to draw our diagnosis here. And again, depending on where you are from, you might use this classification on a different one. This is the American Association of Endodontics classification. We have a pulpal diagnosis and a periapical diagnosis that will be matching, that will be made with each other. We never do just one of them. It's always an apical and a periapical, and a pulpal and a periapical, sorry. And you can see all of them here. I'm not going to describe them. However, there is 2 I want to point out here. The one that we call asymptomatic irreversible pulpitis for pulpal diagnosis, and the one that we call condensing austerities for apical diagnosis. Asymptomatic irreversible pulpitis, it's basically, just to picture it very well, is basically what we call pulp polyp on children. And I'm sure you all have seen that, children that have very large caries. However, you see that the pulp is protruding out of the caries, but the patient doesn't have any pain. You can even test that tooth, it's testing normal. So that's what is an asymptomatic irreversible pulpitis. The pulp is irreversibly inflamed. It will never go back to normal. It will need a root canal therapy at least, but there is no painful sensation. The second one is condensing austerities, and you can see that radiographic aspect here surrounded in yellow. This is just the body. Instead of creating a periapical radiolucency, it's creating bone instead of removing bone. This is associated usually with necrotic teeth. If you treat the tooth, in most of the cases, the condensation will disappear and the bone will regain a normal aspect. So I usually have cases here. I'm trying just to see, we should be able to stay on time if I do some cases with you. Which of the diagnosis may be inaccurate if the patient is already in strong inflammatory drugs? Basically all of them. So just to repeat the question, sorry, is which of the diagnostic tests might be inaccurate if the patient is already on strong anti-inflammatory drugs? All of them. If the patient is taking strong painkiller, especially before coming and see you, unfortunately, it will mask, it could and it will probably mask some of your answers. What I do in this kind of cases is I tell the patient, come back tomorrow. If I cannot get a reliable result, don't be afraid, don't be ashamed to tell the patient, I'm sorry, I'm unable to point at which tooth is the problem right now. Please come back tomorrow, don't take any painkiller, and we will be able to get a better idea about which tooth need to be treated. I prefer to do that more than starting a tooth that might not require root canal therapy or starting the wrong tooth. So let's try to do one or two cases together. I think we should be okay. So I think everyone can see here that radiolucency on tooth number 19 or 36, surrounded in yellow. I'm giving you the clinical testing here. So, and in the meantime, I'm talking, let me trigger. So again, depending of where you are from, you might or might not have, using the endodontic classification, the American Association of Endodontic classification. So try to answer the best as you can. You can see here that tooth number 19 has no response to cold, and the EPT is reaching 80. So if you remember what we just talked about into the EPT section and cold, you should be able to maybe draw a diagnosis here. And you can see that there is an exaggerated response to percussion as well. And again, I don't expect you to know perfectly the American Association of Endodontics classification because I'm not sure you're using this one or not. Let me end the poll here. So I have about, it's almost tight. We have people thinking it's symptomatic irreversible pulpitis and symptomatic apical periodontitis, pulp necrosis, and either chronic apical abscess or symptomatic apical periodontitis. So let me end the poll and give you the what is actually the diagnosis here and why. So the diagnosis here is pulp necrosis and symptomatic apical periodontitis. Why pulp necrosis? Because you have no response to cold as well as an EPT of 80. Remember, if you reach 80, the tooth is considered as necrotic. Now, symptomatic apical periodontitis because there is a pain exaggerated response to percussion on this case. Let me just jump over this case for the sake of time because I still need a little bit of time for the second part. And let's go back to this case we were talking about in introduction. So remember, we've done all of this testing and this is everything we came about as the results. Let me see if I can launch up this one. What do you think the diagnosis here is for that tooth? Knowing that you get a normal response to everything, palpation, percussion, cold, and EPT. This is a little bit tricky one. So I see that some people are saying reversible pulpitis, some people are saying necrotic, pulp necrosis, symptomatic irreversible pulpitis, and symptomatic apical periodontitis. So let me close the poll here and give you the answer and the why. So the answer is normal pulp and asymptomatic apical periodontitis. Why normal pulp? Normal pulp because you have a normal response to percussion, palpation, and cold, and EPT as well. Why asymptomatic apical periodontitis? Because you don't get any pain to palpation or percussion. However, there is a periapical radiolucency, and this is usually the definition of asymptomatic apical periodontitis. Now, to go a little bit further for you, so this tooth has a non-odontogenic lesion. This tooth doesn't need a root canal treatment. There is no need to start any root canal therapy. To go a little bit further, I did a biopsy for this tooth after the cavity test, and the biopsy came back as fibro-osseous lesion. So lesion that has fiber and kind of osseous part in itself. The two differential diagnoses from that biopsy could be ossifying fibroma or focal cemento-osseous dysplasia. The only way to know what it was is if it was ossifying fibroma, the lesion would have continued to expand with time. So we decided to wait 6 months. You can see that 6 months later, the tooth has been restored in the caries. The lesion is still same size. It is then a focal cemento-osseous dysplasia, early stage. Remember, there is 3 stages for focal cemento-osseous dysplasia: early stage, periapical radiolucency; second stage, it will be radiolucent and radioopaque, like a mixed lesion; and late stage, radioopaque lesion. And that was our first part. So let me move on the case selection part, and I might go a little bit faster on this, sorry, just to try to stay on time for the next presenter. So case selection. In case selection, there is a couple of very important things. The first one here is the medical history of your patient. And because depending on their medical history, you might change a little bit the way you're approaching that case. So for example, if your patient have an unstable angina, I don't advise you to treat that patient. Usually this patient are hospitalized, so there's no need to treat them. If they have a myocardial infarct of less than 3 months, you want to not treat them, and usually they're probably either still in hospital or recovering. If they have a myocardial infarction of more than 6 months, you want to limit the number of anesthesia, and especially epinephrine you're giving to that patient. And that's the important part here. You want to limit yourself at 2 carpule of whatever solution you're using with 1/100,000 epinephrine. So here again, this is the medication that are prescribed in America. Depending of your country, could be the same, could be a little bit different, but I imagine it's the same name. So the very important point is patients who have high blood pressure, and we have a lot in the US, to be honest. These patients, sometimes they are taking non-cardioselective beta blocker. So you have selective beta blocker, but this one doesn't have any specificity with our treatment. The non-selective beta blocker are the ones that have something that we need to be very careful of. And this is the amount of epinephrine you're giving them. Again, I have placed all the name on the left side. So when you review this lecture, you can see if your patient is taking, for example, one of this medication. And usually propranolol is the main one for the non-selective beta blocker. And you want here as well to limit yourself as 2 carpule of whatever solution we're using for anesthesia with 100/100,000 epinephrine. Why? Because if you don't do that, you might create a hypertensive crisis on the patient, which means very high blood pressure. And this becomes a kind of vital emergency that you probably don't want to deal with in your office. So remember that. Then let's switch to pregnancy. And remember, 2nd trimester as the best trimester for elective treatment. 1st trimester and 3rd trimester, you don't really want to treat the patient outside of emergency care. I have placed here the table of what is safe or not safe to use for pregnant patient. You can see that usually the B class or level is the one that we want to use. So for example, lidocaine or acetaminophen for the pain, clindamycin, penicillin, this is definitely something you can use, and you can review that on your own time. There is a slide that I didn't include it here for you because the system is changing in the US with the FDA recently, but I don't think it will impact most of you, so I have excluded it from here. Antibiotic prophylaxis. Very important one. Does your patient requires antibiotics prior to your root canal treatment? If pregnant, attend to clinic with huge pain in first trimester, what do you want to treat the emergency. So if the patient is in the first trimester and come as an emergency, please treat the patient. You need to treat them. There is no question. It's just you don't want to do any elective treatment. So what I will do is I will probably do the emergency procedure and finish my root canal treatment during the second trimester. Now, if the patient come in third trimester, I will do the emergency procedure and delay the finishing of my procedure after the delivery of the baby. So antibiotic prophylaxis, when is it needed? These are the only cases where it's needed now. So prosthetic cardiac valve, previous endocarditis, and I let you read it as well. But this is very narrow scope now. We almost don't need to give antibiotic prophylaxis anymore. And especially when we're talking about prosthetic implants, at least now in the US, we don't give antibiotic prophylaxis anymore. There is a little asterisk because if the patient tells me, oh, my surgeon or my doctor wants me to take the medication, I don't overrule it. They can take it. It doesn't change anything for me. But if they don't, there is no need for me to prescribe anything. In your case selection, what is extremely important to remember is endo is usually the first treatment that is done. And then stuff come after, perio, restorative, and post. However, when you treatment planning, you should keep in your mind that endo should be the last things you think about. You should first think about prosthodontic and restorative aspect of the tooth. Can it be restored correctly? Perio, does this tooth needs a crown lengthening? And then down the road, does this tooth needs, can I treat this tooth? Because I can treat, and you can treat, I'm sure, teeth that are cut at the gum level, but can you restore it? Maybe not, and probably not. Are you doing something good for your patient? So that's why keep in mind that in your treatment planning, endo should come at last, and then will be the first part of your treatment that is clinically done. So when we're talking about prosthodontist and restorative consideration, you want to look at restorability of the tooth. Do you have enough ferrule on this tooth? You want, remember, at least a 4 or 5 millimeter of abutment height as well. And you can see on the right side, intraoral pictures, you probably will need either a crown lengthening for this tooth or probably just an extraction. Second point is you want to assess the quality of the previous restoration as well, very important. And you can see here on this tooth surrounded area, on these premolars, that there is a defect under this restoration, and that probably this restoration needs to be removed before deciding to do any root canal therapy. You need to assess that restorability of these teeth. Restorative treatment plan should always be decided prior to any root canal treatment procedure. Keep really that in mind. You want to look at periodontal status of the tooth. You want to respect the biological width. Oops, sorry, there was a typo on width, or supracrestal tissue attachment. How is it now in the new classification? And you can see here, Dr. Shi, which happened to be my wife actually, has nicely giving me this radiograph where she did a nice crown lengthening, and you can see a nice restoration down the road. But you want to make sure that the tooth doesn't need a crown lengthening before you decide if this tooth can receive the root canal therapy. And remember, you really want to probe. Again, I'm just emphasizing that, sorry. Remember that the narrow isolated pocket here on the left side is usually what could be indicating of a root fracture. So how do you know if a case is difficult, very difficult, easy? You can use, for example, the AE difficulty case assessment. They even have now an application that you can download on your phone. However, I think this is very complicated to use in a clinical setting. It is a little bit difficult. So I want to share with you this. This is the difficulty case assessment that I have came up with. That is very easy to use, and this is something you can use in your office to know if a case is average or if it's going to be a difficult case that, depending on your level of expertise, you want to treat or maybe refer. So obviously, first, is your patient opening a lot? You can see that if the patient is opening like only 2 fingers on the upper pictures, it's going to be a very challenging case if you're treating a second molar, for example, where a patient that opened at least 3 to 4 fingers on the bottom, it will be like almost a walk in the park. Next, you want to look at gag reflex, because people who have high gag reflex when you place your rubber dam, and I hope every one of you are using rubber dam during your root canal therapy, and radiograph, it might become challenging. Medical consideration. If your patient has ASA 3 or 4, it will become a challenging treatment because you might have to adapt your treatment in ways. Remember, if your diagnosis is very inconsistent, it might be wise to refer that to an endodontist or a provider more experienced to either treat the tooth or decide if these tooth need a treatment or not. Radiographic assessment. So obviously, if you see a very large pulp chamber, very large canal, as you can see on this periapical radiograph on the upper right side, it will be probably an average case. Now, if we look at this case here, I don't see any pulp chamber, I don't see any canal. This will be definitely more advanced and difficult case to deal with. It doesn't mean you cannot, because you can see the two post-op radiograph on these two cases. It just means that you might need a little bit more level of expertise or to treat this teeth. Tooth, depending on the tooth you're treating, it might be easier or not. If you ask me what is the worst tooth to treat, it is a lower anterior with a crown. I hate them. So narrow, you really have no space for mistake. After comes premolars. People think that premolar are easy teeth to treat. I completely disagree. Very narrow at the CEJ level, very easy to perforate. And then they have this usually nasty little curve as well at the end of the apex that requires a lot of filing. And finally, first upper molar. Please remember that in first upper molar, there is, depending on the study, between 75% and 90% of MB2. If you don't find MB2 on every 7 to 8 cases you treat, you're probably missing some of them. So it might be interesting for you to either send to an endodontist or maybe discuss with someone who has a little bit more experience to try to find them more often. The presence of a crown can be challenging as well. Remember, when there is a crown, the occlusal anatomy of the tooth is not respected anymore. You can have some overhang area. So for example, if on this tooth, you do your regular access, like in the normal tooth that doesn't have a crown, you might end up perforating in mesial, as you can see here. You will have to change the way you're approaching your access on that tooth, making this case a little bit more advanced. Previously treated teeth are obviously more complicated depending on your level of expertise, and canal curvature. If there is no curvature, average case, not much difficulty. However, like on the bottom right side radiograph, if there is some high curvature, more than 20 degrees, it might become more challenging because you need to have a little bit understanding of the metallurgy of your file to make sure that there is no instrument separation or ledge situation, but this teeth can still be treated. Last point I want to make before we conclude is the time and money aspect. And not a lot of people are talking about that, but I think this is a very important aspect. So again, depending on where you're practicing, this might be accurate or not that accurate. I decided to compare a root canal treatment, the cost of a root canal treatment in cost and time, and just a crown placement. So here in Denver, for example, the root canal treatment on the molar is about, in average, $700, and the crown will be on an average of $700 as well. Depending on your level of expertise, let's say a molar root canal treatment will probably take you about 2 hours, where a crown placement, so the crown prep impression, will probably take you about 40 minutes. And I think you can start to see where I'm going with there. If you do a root canal treatment for 2 hours, so 120 minutes, you're basically producing $700. Now, on the other end, if you do 3 crowns in the same time, because 40 minutes, you can produce $2,100. So I think you should ask yourself in this situation, do I want to do this challenging root canal therapy and maybe lose a little bit of money? Or should I send it to someone, it's the specialty, and make a little bit more money by doing more crowns in that time? So remember, this is all the factors you want to look at in your case selection: health, post-restorative, periodontal, periodontics, and financial aspect. And it will help you to decide if you want to treat or refer. Perfectly on time to conclude for today. What I want you to remember, and as a take-home message, is when you're trying to make your endodontic diagnosis, please refrain to make it from just a radiograph or just a chief complaint of the patient. Get all of the information. get your chief complaint and medical and dental history, get your clinical findings, and get your radiograph interpretation in this order. Look at the radiograph in last, and then draw your diagnosis from there. And I have put in everything we talked about here for you to remember, and you should be able with that to make your treatment plan. Remember the chronology of testing I talked about earlier. Same, first you should always do palpation, percussion, probing, and cold test. And then if the cold test is negative or inconclusive, you should do an EPT. And if you still don't get the results you want at that point, you can try to match the chief complaint with a heat, bite test, or trance illumination. This we just talk about all the important factors you need to look at in your case selection. Remember, the financial aspect is the one that people don't talk about a lot, but you want to consider. And all of this should help you to drive toward the right treatment, either referral, an extraction, or you treating the patient. And there is a very good relationship with endodontists and general dentists. So remember that, depending of if you have endodontists in the country you're practicing in, don't be scared, afraid, or to just go there, talk with them, talk about your cases. We're usually very happy to talk about cases with our referring dentist. Just a quick book recommendation. My case difficulty assessment, the way I came up with is from this book, The Checklist Manifesto by Atul Gawande. Some of you might have read it, extremely short and good book about checklist. And he's one of the person who came up with the pre-operative checklist in the OR, in the medical field. If you know them, it's a very good book. So thank you. I think I'm perfectly on time. And if there is any questions, I think there is one more question in the Q&A. And then if you have more questions, I can answer more questions. Let me just answer this one. Can a previously endo-treated tooth with a grade 2 mobility, chronic abscess, and paralysis be saved with a root canal therapy or apicoectomy? So this is a very specific question here. Thank you for the question. It is difficult for me to just answer in this way without a radiograph, first of all. Again, it goes with what I was just showing you in this presentation. You giving me here only the results of your clinical testing. Basically, I don't have an idea of what's the patient's, like the patient side of it, and I don't have a radiograph of it, making it very difficult for me to really give you an idea of a treatment. It could be, it could not be. It really depends of how is the lesion. It really depends of a lot of different factors. I cannot just give you a straight answer from that.
All right.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator